and thank you for being there. Excellent. And Megan, are you going to admit all people in 1 minute?
I'm happy to do that.
Thank you.
It's a nice turnout. There's a lot of people waiting.
A lot, yes.
Yeah.
Shiva, you just say the word and then I'll admit everyone.
Sure. Sure. Yeah, we can admit. We are ready.
Wonderful. Okay, here we go.
Hello, everyone, and welcome to the Connecticut Psychological Association Social Justice Speaker Series. We are honored to have Dr. Jonathan DePierro as our esteemed speaker tonight. Dr. DePierro's talk title is The Science and Practice of Resilience. What helps people adapt and thrive in the face of stress and trauma? Drawing from research with healthcare workers, 9/11 first responders, veterans, and community members, Dr. DePierro will share insight from cutting-edge neuro-imaging studies and resilience-building programs implemented in New York City. A warm welcome.
Hi, everyone.
My name is Shiva, and I'm the chair of the CPA Social Justice Committee. Joining me today are our dedicated social justice members, Beth, Kyler, Lena, and unfortunately, Anne and Andrew will not be able to join us. But we are grateful that Dr. Jennifer Doran is with us and will share the biography of our speaker. Now I'll turn it over to Beth to share about our generous donors who keep this essential work going.
Thank you, Shiva. The Social Justice Speaker Series serves as a catalyst for our shared goals to empower ourselves, our clients, and the community we serve. To sustain this essential work for you, we depend on fundraising and the generosity of those who believe in the power of education and awareness of our biases. We sincerely appreciate all donations moving forward and are genuinely grateful to our sponsors. Your support is the foundation that keeps this vital work alive and thriving. We have up on the screen now our supporters, and want to recognize Comprehensive Neuropsychological Services, who supported us for the 5th year in a row, and CPA Educational Foundation, who supported us for 3 years in a row. In addition, Stacy Tata has generously donated $5,000 to our cause in memory of her beloved parents, Dr. Jack K. Plummer and Lynn Tata Plummer. In addition, we have our supporters in 2025 of Robert Bourgeois and Shiva Resvin. We appreciate all these donations, and this is what keeps us going. Now I'll pass it on to Lena to share more information with you. Thank you.
Thank you, Beth. Hi, everyone. On behalf of the Planning Committee, we are thrilled that you could join us this evening, and we sincerely hope you will continue to attend our future speaker sessions. We are excited about Dr. DePierro's presentation tonight. And as a brief reminder, the CPA Social Justice Speaker Series offers free monthly meetings to CPA members, the wider community, Connecticut community, and our nationwide supporters. I welcome you to our speaker series this evening. I will now pass it to Jennifer to present the biography of our esteemed speaker.
Thank you. So I have the privilege of introducing Dr. Jonathan DePierro because he and I actually went to grad school together. So we've known each other for, goodness, more than 10 years. And I have very high respect for his work. I'm very happy that he's here. So Dr. DePierro is an associate professor of psychiatry at the Icahn School of Medicine at Mount Sinai and the associate director of the Center for Stress, Resilience, and Personal Growth. His work focuses on advancing research and interventions that strengthen psychological resilience and support recovery from trauma among healthcare workers and other high stress populations. I'm so honored to have Dr. DePierro here tonight to guide us through what promises to be a very insightful and inspiring presentation. Dr. DePierro, the stage is all yours.
Hi, everyone. So I'll be talking today about work that's largely done at Mount Sinai at our Center for Stress, Resilience, and Personal Growth. It's inspired by many decades of work at Mount Sinai and elsewhere, including Yale, understanding psychological resilience from lots of different populations. Actually, I see Bernadette Southwick is here. Her husband, Steve Southwick, was a huge contributor to a lot of the foundational understanding of resilience and its measurement and beginning to apply it to practice as well. So I'm going to jump into some slides. You can feel free to interrupt me. I might even call on some folks. Jen, I know you, so I might call on you at times. And I'll leave time for questions at the end as well. Okay, continue to share. Okay, so just a few disclosures. I receive book royalties from Cambridge Press. I'm also an editor-in-chief of a journal at Springer Nature. And I'm named on some patent applications, but I'm not going to be talking about those technologies today. So, the word resilience is in my talk, and it isn't really a trivial matter to think about how you define resilience, because how you define resilience impacts how you measure it, how you build it, how you treat it. So there's been a lot of debate in the field over the past 20 years, at least, on what is this thing we call resilience? Is it resistance to developing an illness? Is it ability to recover from an illness? Is it bouncing back? Is it adaptation? Is it growth even? So I'll be entertaining a few of those different definitions today, but I want you to keep it in mind that there actually isn't agreed upon universal definition of what resilience is. There's an APA dictionary definition, but even that maybe has some limitations. Some of my influences in understanding resilience come from work. Jen and I did this work with 9/11 first responders. There's been 25 years almost of research in measuring people's coping and adaptation to the 9/11 attacks. I think at this point, 40,000 responders are followed by Mount Sinai on at least an annual basis. So there's a lot of data that's collected and a lot of good work that's done. Our center, CSRPG, came out of the COVID-19 pandemic and was founded in June of 2020. And a lot of work there is focused on understanding sources of resilience in healthcare workers, both nested in the individual, but also within the system. This is actually the lobby of Mount Sinai turned into a temporary field hospital during the early months of the pandemic. Thankfully, we didn't have to use those units, but there's a Starbucks right behind there you can't even see. Famous lobby turned into a hospital. We did a lot of interviews and we've done a lot of work with the military. Our former dean, Dennis Charney, and Steve Southwick interviewed Vietnam War POWs, and a lot was learned from them and from special forces folks about facing their fears, about facing adversity and surviving and even thriving in those circumstances. Over the years, too, a lot of work has been done sort of almost qualitatively, understanding resilience by interviewing people and figuring out what the themes are that come out of those interviews. So POWs, people who've been through medical illnesses. This is one of our physicians who actually talks openly about having a heart transplant during her training. She had to have a heart transplant and talked about that on a podcast we recently did. And we write about it as well. This is one paper that I really, really like. It's one of the most cited papers about resilience, and it's 5 experts in the field essentially having a heated debate about what resilience is. So I encourage folks to look at that. Steve Southwick is a first author on that paper. Our podcast at Sinai is Road to Resilience. I've hosted a few of these episodes. It's not my podcast. It belongs to the system, but it's a really great way of hearing from platform for people to talk about their stories of personal resilience. This is one definition of resilience that we're probably all familiar with from graduate school. This is work of George Bonanno, understanding that most people show what is called a resilient trajectory. So we know this epidemiologically. Most people who go through a traumatic event do not develop PTSD, anxiety, depression, or any sort of lasting psychopathological outcome. Like 85%, even 90% of folks are resilient in that way. And he calls essentially the absence of persistent psychopathology resilience, and then there are labels for other trajectories following illness or other personal adversity. One of the limitations to me to that is it's a great shortcut, but it also overlooks the resilience that people might have in recovery and while they are struggling through depression, anxiety, and other conditions that they faced after trauma. So calling just the people who don't develop PTSD resilient is limiting and maybe doesn't give credit to the folks who are working through something challenging and have worked through something challenging. So that's kind of one critique I have of that model. Great model in understanding epidemiological data, but maybe not so much in terms of what we understand clinically when we sit with patients. Arguably, happy to have a debate about that. This is a definition from Rachel Yehuda that I really, really like. Rachel Yehuda is one of our vice chairs of psychiatry, does a lot of work in PTSD, worked with Holocaust survivors, does a lot of work in psychedelics now, runs a psychedelic center at Mount Sinai with veterans and others. And she calls resilience a reintegration of the self that includes an effort to move forward in a positive manner as a result of lessons learned from adversity. So for her, there's a kind of suffering and growth component to resilience. Something happens, it shatters your assumptions about who you are and what the world is. And that gluing yourself back together or being glued back together process, that can be painful and tough and a challenge. And even moving forward is how she thinks about resilience. I actually like that definition because it includes the aspect of it being tough. It's not easy, and it comes with suffering. And we'll see that when I talk about post-traumatic growth later. So this is one way, and this is a paper I really like that sort of does almost like a factor analysis of the brain networks associated with resilience and how they map onto different psychological constructs. So if we think about resilience in this perspective, they think about three different buckets, basically. Regulating the positive, so boosting positive emotionality, connecting to optimism, which we teach people, humor, which I try to embrace, connecting to positive memories, journaling, gratitude exercises, physical exercise, social connectivity, sort of boosts your connection to, attention to, memory for positive emotions, your visceral experience of positive emotions. That's obviously undergirded by the reward networks. Regulating the negative, so difficult negative emotions come up, so regulating the intensity and frequency of those. So CBT is really helpful there. ACT-based approaches, reappraisal. We actually teach people, cognitive reappraisal. We do a lot of work teaching the workforce these kinds of tools, even in an educational manner. Exposure therapy is really all about that. And it's really down-regulating the sort of fear circuitry, which the shortcut here is the amygdala and the HP axis, but it's obviously much more involved. There's the insula is involved in that as well, brainstem. And getting out of your own head. They call it here transcending the self. Things like mindfulness, having purpose in life, connecting to spirituality, connecting to something greater than yourself, and kind of seeing yourself seeing your issues and difficulties with some perspective. And that's related to downregulation of the default mode network. And in this sort of neuroscience of resilience paper, those are the sort of three different components that they looked at. And in our trainings that we do with the workforce and with other groups like first responders, I've done some work with the FBI as well, we sort of touch upon each of these different areas to focus on in terms of building psychological resilience. We also think about resilience at a leadership level and a macro level, and I'll get into that a bit later too. Okay, so what do we know about some of these psychological factors in resilience? I'm going to talk about an example from our workforce. So interestingly, 3,000 of our healthcare workers did surveys in the first months of the pandemic. And from that, we were able to abstract what factors were most protective in terms of buffering against the adverse effects of the pandemic psychologically. The first three factors here that had the highest loading in this relative importance analysis, so the big bar means most significant. Jen, this is Rob Petrusak's work, so he always does fancy statistics and has pretty graphs, are positive emotion words. So the more they were able to connect to different positive emotions, even in the thick healthcare workers, in the thick of the worst situation we can imagine, the better off they were. Having a purpose in life, connecting to social support. Leadership support, importantly, is in the top 6 or 7 here. I'm going to come back to that. If our healthcare workers said that they had a supportive, present, visible, communicative leader, they did better. They were less likely to screen in for depression, anxiety, and PTSD. If their leader was absent, didn't give clear directions, gave confusing directions, they were more likely to experience PTSD, depression, anxiety. We actually show that even now. We did a study last year, we're about to publish. It's actually under peer review, shows exactly the same thing. Even outside the acute waves of the pandemic, your perception of leadership support is directly related or associated with your own personal mental health. So really strong role of the leader here in the system. We will not, and again, this sort of goes into this next idea. There are different ways of thinking about resilience as almost like a nesting doll, where we have the biological systems, the psychological systems where we all sort of live as psychologists, the social environment, built environment, and so on. I'm going to talk today somewhat about biological, definitely a whole lot about psychological, and I'm going to talk about leadership and system level variables as relates to the social. There needs to be obviously a lot more done with the natural and built environment, but when we think about resilience, we have to really think about this whole situation, not just the individual, because the individual is nested within a context, and we sometimes lose sight of that. And certainly researchers about resilience have essentially, some people have basically said, oh, all that other stuff is too complicated. Let's just study the individual factors. We can measure that on a rating scale. But all this other stuff is really, really important to keep into consideration too. So let me tell you a little bit how we translated this. And as I said, Bernadette is here. Steve and Dr. Charney did a whole lot of work writing about personal resilience. We had the 3rd edition of this book about a year and a half ago now. And what we did very early on in the history of our center is we sort of took this academic content and we translated it into training manuals. And we've done over 600 courses with our workforce. We're involved in 25 or so different residency programs at Mount Sinai. We have the most medical residents and fellows of any program in the country. And as part of their training, as part of their didactics, they're going to learn about cardiology and lung health and all of that as part of their typical didactics. They get time in that didactic schedule to learn about resilience and mental health awareness. It's built into their curriculum and treated like any other class. And so we've done this quite a bit. We train them all together because they work together. We've done this with different kinds of, different people in the workforce, different occupational groups, not just residents, nurses, nurse leaders. I'll give some examples later of how we've adapted this. We do actually ongoing work with security officers. I think we're the only folks writing about hospital security officers and their needs and quantifying that. But this is sort of baked into the operations of a lot of units now in the health system as relates to our work. We also did work with the community. So very early on in the pandemic, we partnered with faith leaders in the community, largely in churches in Harlem and the Bronx and Brooklyn. We took our manual, we integrated scripture with their collaboration, and those faith leaders, after Sunday services, taught their congregation in 2022 and late 2021 about resilience. These communities that were very hard hit by loss, they integrated this into their conversations and the education that they're doing in their churches. This is part of a larger health education program that Mount Sinai had been doing for a number of years, but we added this resilience component to it. We called it the Building Community Resilience Program. Now it's actually being continued with NIH support, co-I on a grant from NIH to do this with community-based organizations in New York City. So folks who run soup kitchens and shelters and other groups, we train them about different resilience factors, and they in turn teach their the membership, the folks that use their services. And we wrote about this as well. So again, translating basic science concepts to something practical and then sort of extending that within our Mount Sinai health system, but also to the community at large. And I'm going to get into some of these factors in more detail in the rest of my talk, but really what I like is this translational effort, taking something that's complicated about maybe a stressed rat in a laboratory and making it tangible and usable for someone in the community. One other example of this that I'll give and how we've done this translation is what we learned very early on, even during the pandemic, was that there were some members of our workforce, like residents or fellows or even faculty, who could afford in their schedule to do a training for an hour or do 5 trainings for 5 hours. But there are a lot of folks in the workforce, like nurses, who simply didn't have the time or their unit couldn't afford to lose them for 5 hours because they were so busy. So we were actually very lucky to get a grant from HRSA. There was the Lorna Breen Foundation advocacy that led to grants being afforded to or given to 30 organizations across the country. I think we had 2.5 months to write a really large grant application, and we were lucky to get this. And so what we did is we took these long format workshops that were typically an hour and condensed them down to 10-minute conversations. And we went to ICUs and emergency departments and spoke to nurses at 7 o'clock in the morning and 7 o'clock at night for 10 minutes for 13 consecutive weeks. So we'd go, say, on a Tuesday, 7 o'clock in the morning. That same Tuesday, we'd go to the night shift, 7 o'clock at night, and we went that same day of the week for 13 straight weeks. So we had a manualized approach where we sort of condensed it down, gave tiny little bits of information about mental health awareness and resilience to the workforce because we knew that those folks could not get off the unit to do any sort of longer format training. And there was the same psychologist or social worker going every single time. So we built a relationship. And what we found, a few different things, but one of the important things is that we found, and this is an important through line for the work that we do on resilience, is that social connection and trusting relationship is really, really important. One of the most reliable resilience factors is social support. They felt supported by their leadership, that this was made available to them, and we just went to them. We didn't do anything to obstruct their work. Their leaders had to do training too as part of this, but they felt supported in this, and they got to know us personally. And if something bad happened down the line, and stuff did, they reached out to us personally because they got to know us individually. This is an example of some of the topics that we talked about in this huddle program. So again, just brief conversations. This was a 2.5-year effort. We published on this as well. We manualized this approach, and we took attendance during this. So we had a little QR code that the nurses scanned and other folks scanned. So we got their attendance information, and we also asked them to give us feedback every single time. So in addition to doing training, we actually were able to do a fair amount of research as well about the efficacy of the program. And what I'll preview here, we're about to submit for publication, I hope tomorrow, is that there was a dose-response relationship between attendance in the huddles and institutional turnover over a 3-year period of time. That is to say, for nurses and other staff who attended four or more of these 13 huddles, that's the magic number, 4 or more of 13, there was a significant reduction in the rate of turnover relative to attending one huddle. So there's also a business case for this too, sort of operationally. You provide a brief intervention, and there was some signal for decreased turnover over the period of the grant. People really liked this. This is just a sampling of the outcome data, but even in that brief conversation, they felt less stressed afterwards. They felt that leadership values them by making these, us available to the unit, increased ability to bounce back. That's kind of our face valid item about resilience. It gave them tools to do their job at work and for their life outside of work. And this was something that we published on. This is an open access paper, so you can read it if you'd like. I'm going to talk now. This is actually one of the illustrations from the book, and I kind of like it because they're like this person's facing down little ghosts in little scary figures in the clouds. I'm going to talk a little bit about some of the topics that we cover, and as psychologists, we know these very well, and we teach them to patients, but I'm going to give some examples of how we translate it to the workforce and to other groups that we work with. We do some work with nonprofits, as I said, the community, and a little bit of law enforcement work as well. So one of the topics that we really focus on is cognitive flexibility, facing fear, and active coping. And a lot of the work that we do with residents is teaching them to essentially do CBT on themselves. And we all know those of us who've had CBT training know that CBT essentially comes from Stoic philosophy. And these are just a few quotes. Two of them are Stoic philosophers, one isn't. You can pick out the one who isn't. It's Viktor Frankl. He's not a Stoic philosopher, but talks in that language. And Marcus Aurelius, and we talk to scientists about this, they kind of like this approach too, when we train them. If you're distressed by anything external, the pain is not due to the thing itself, but your estimate of it. And this, you have the power to revoke at any moment, which is to say, it's not the event itself, but it is your appraisal, interpretation, or thoughts about the event that cause suffering. So we hear CBT here, we hear CPT here, in teaching people to capture their immediate reactions to situations. I kind of like the Seneca quote too, which I recently discovered. Life is very short and anxious for those who forget the past, neglect the present, and fear the future, which is many of the patients we see with depression and anxiety disorder fit into this bucket. Why is this important? Our research, actually, this is research done by colleagues, not me, but our research group at Sinai very early on, found that essentially CBT, if people on their own, without being taught, just happen to use CBT strategies, reframing, humor, connecting socially, residents, these are medical residents who use these CBT strategies more often on their own to cope with the pandemic and that stress were much less likely to screen in for PTSD. So if they had this in their toolbox already, it helped them deal with the stress and not develop PTSD. Again, not a causal relationship because this is all cross-sectional data, but it really mattered to have these tools in your toolbox. These are pretty impressive effect sizes and statistical relationships. And this is the shortcut. This is actually stolen or cited appropriately, I would say, from the British Psychological Society, the catch, check, and change model, which is a really great way I find to teach people CBT. Catch a negative interpretation, check the facts, and change what doesn't make sense or what's not helpful or realistic. And these are some of the questions, again, if you know CBT and you practice this with your patients, you probably say these questions 10 times a day at least. Is the thought realistic? Is it helpful? What's the evidence for and against? I like using the metaphor of like being in a courtroom and having a very sleepy defense attorney and a very active prosecutor. And in CBT, you want to wake up the defense attorney and like poke them and make them object to things. What would you tell a friend going through the same situation? And will it matter a year from now, 5 years from now? So when we teach people to ask themselves these questions in these workshops that we do with the workforce. Again, taking something that we do with patients and using it, applying it in sort of a preventative medicine approach. I'm going to talk briefly about optimism as a resilience factor. And again, just like social support, which I'll talk about in a moment, optimism has a significant research base behind it. Optimism not meaning toxic positivity, but meaning focusing on what's within your immediate control. So I guess Vietnam POWs were really popular to study back in the day. So this study was a 35-year longitudinal study of Vietnam War POWs. And optimism, essentially coming off the plane after being in the POW camp, because they were handed a whole bunch of surveys, optimism at that time in the 70s, early 70s, predicted or was associated with decreased risk of PTSD 35 years later. So those POWs who came off the plane had been tortured, starved, so on, coming back to the US, those who were more optimistic, I think they must have used a version of the MMPI, were much less likely to screen in for PTSD. Same true for veterans in more contemporaneous studies, survivors of cancer, optimistic older adults actually live longer and have better cardiovascular health. So it has a real physical correlate as well. And this is a diagram that's a little busy, but we actually use to teach people about optimism and pessimism. And the idea here being that we can catch it in how people respond to stress and the words that we use to talk about stress and our reaction to it. Actually, Jen and I were both at some point in a lab at the New School that looked at word use and its relationship to PTSD and stress. But pessimists, when they encounter challenges, tend to think about them in absolutist terms. They use black and white thinking. I'm going to feel bad forever. This is going to ruin everything. My life is a mess now. I'm going to be struggling for a while. There's no light at the end of the tunnel. Everything's awful. I should just, give up. We hear this all the time from our patients, right? They use always and never categorical thinking. They encounter stress and they think in absolutist terms. The stress is pervasive, permanent, universal. It sort of ruins everything and is spread like a virus. People with a bit more optimism see the stress and its impact as having a limit around it. They put a frame around it. It's temporary and limited in scope. One part of their life is affected for a period of time, not forever and not everything. So they use sometimes lately, this thing is difficult, but this thing is not. They are able to put boundaries around their challenges and focus on what's within their control and what's not. Again, reflected in the words that they use. Everybody with me so far? Any questions? I'm actually doing pretty good on time, so I'll have plenty of time at the end for questions. And what we teach people is trying to build their optimism, try to catch their negative interpretation of events, make space for positive or more realistic thoughts by marking their successes. I tell my staff to keep an email folder of positive things that patients have said about them or good outcomes or good interactions. So on a bad day, they can go back to that email folder and realize that they're not a bad therapist or colleague or researcher. Because again, when we feel that stress, we see everything in the past pervasively as negative. We lose sight of the positive things. We try to teach them to catch rumination by scheduling worry time, which I'm not going to talk about. And one of the things that I really like, there's this book by Rear Admiral, his last name is McRaven. He has a graduation speech from University of Texas, and the whole point of the speech is about making your bed every morning. And he says that if you make your bed every morning, you start your day having succeeded in something. And if you have a bad day, at least you come home to a bed that's made, and you could say you've accomplished one thing. And accomplishing one thing gives you the impetus and energy and enthusiasm to do another thing and another and another. And it's not necessarily about making the bed per se, which I don't do, but about having one thing every day that you could say you accomplished and did well. And you use that as sort of the foundational starting point for other things. And this is actually sort of has a kernel of behavioral activation in it, which we do as we teach people as therapists. We also talk about faith, meaning, purpose, and spirituality, and some people shudder at this. Scientists talking about religion, but it is very meaningful. 85% of the world identifies with a organized religion of some kind. And again, coming back to some of these quotes, Viktor Frankl again says, life is never made unbearable by circumstances, but only by a lack of meaning and purpose. And I'm going to connect to this in just a moment by talking about sources of meaning. And so out of the work of Frankl and adapted by folks at Sloan Kettering and even Dr. Southwick, we think about connecting to sources of meaning as an important answer to a sense of burnout. So when people say, I'm burned out professionally, oftentimes they mean that they've lost connection with the important and most meaningful aspects of their work. They've gotten bogged down in the paperwork, the administrative hassle, the all the red tape, and they have lost connection to the positive interactions with patients or even any interaction with patients. And we really try to teach people to connect to the different sources of meaning in their lives. This is essentially directly from Viktor Frankl's work. The historical legacy, the legacy that they are entering into as a physician or healthcare worker, the role that they play, the teaching and mentorship that they might give to others as both a professional and as a family member or parent or friend, the attitude they take when they face suffering. And people derive a lot of meaning from the choices that they make amid suffering. Dr. Southwick talks about this, and there's the epilogue to our book is really about his navigating his advanced cancer diagnosis and end-of-life journey, and really choosing his attitude toward that and leaning into mentorship and love and connection in that time. And that was deeply meaningful to him. Connecting to creative pursuits, I lose track of that myself. I did a lot of art in high school and college and haven't picked up that in a while, but I'm trying to again. And experiential, connecting to meaning through humor, love, nature, actual visceral sort of sensory experiences. I have that sense of awe, and it's kind of corny, but when I walk into the hospital in the morning, I look up and you can see in the atrium the sides of all the floors, and it's kind of like walking into Bellevue. If anyone's ever walked into Bellevue in the front door, you feel like you're part of something huge. You are, but you have that awe experience when you're, confronted by this. You're a part of something greater than yourself. And I'll just say a few more things about this, meaning and purpose. This relates to this idea of post-traumatic growth. And one of the things that's important to understand about post-traumatic growth is that it's not all rosy. When we talk about, we write about, and research post-traumatic growth, what has been very clear, and this is from Rob's work as well as others, is that there's a curvilinear relationship between post-traumatic growth, seeing positive changes in your life as a result of or following trauma, and symptoms, whereby people with low levels of PTSD symptoms or general distress have almost no growth that they report. People with a lot of symptoms, like the most extreme end, have also almost no growth. But the moderate symptoms of PTSD, those folks who endorse that have the highest level of reported post-traumatic growth. So it comes along with, and might even be catalyzed or motivated by some degree of suffering. You've been through something, it's impacted your life, you've developed symptoms, and now you have to ask yourself, now what? Who am I? What do I do now? And that asking yourself those questions can facilitate a process of looking at ways in which you've grown. But it is due to or in parallel with a lot of suffering. And I think that might be missed in our conversational understanding of post-traumatic growth. It might just be seen as the silver lining or rosy, but it's not that. It actually comes with a lot of suffering, and the suffering is part and parcel to it. And just a little bit of evidence from our healthcare workers to show that. So these are different aspects of post-traumatic growth. So if anyone's ever looked at a PTG scale, there's a new sense of appreciation of life, new relationships to others, new friendships, new sense of your personal abilities, new sense of possibilities in your life, and spiritual changes. And these are the different PTG domains. And when we asked healthcare workers in the first phase of the pandemic in 2020, 2021, if they experienced changes in one of these domains, it was those healthcare workers with PTSD symptoms screening in on a PTSD screener that endorsed the highest levels, or that had the highest rates of endorsement of any of these domains. You can see the red line is those with PTSD symptoms. And that might be surprising, but that's a consistent finding in literature. It's those with those symptoms where they're almost forced to figure out, who am I now? I'm just going to check the chat to see if there's... okay. Does anyone see the slides? Everyone sees the slides? Okay. Oh yeah, I saw, Jen, your comment, Rob. Dr. Pietrzak did just win a award for a lot of his work. He's like 800 publications at this point. And again, while people might shy away from talking about spirituality and religion, there's a huge amount of research on its mechanistic relationship to mental health and physical health. You can just take an example. Imagine someone say in New York, you got a 70-year-old woman, 70, goes to church every Sunday, or temple or mosque. What does she have to do? Well, she has to get up on time, shower, get dressed, physically go someplace. People are looking forward to seeing her. She's looking forward to seeing people. They're hearing optimistic things, probably. They're getting messages, and they have a meaning system and system of spiritual connection they're being part of. And they have something to look forward to the next week and the week after that and the week after that. They might even do volunteerism or different work in the community associated with that. It gives a sense of community, a sense of meaning and purpose. There's a physical activation component because you actually have to get dressed and go someplace. And you have a reason to go on. You have something to look forward to, and a worldview that you can use to understand hardship in your life. And I will say on this note that spirituality and religion is not necessarily always helpful. There's something called negative religious coping. And if you think, for example, that God is punishing you for something you did or didn't do, then obviously that is not so helpful for your mental health. But we're talking about sort of positive on the positive side. It's not always the case that it's helpful. It depends on how you are applying it. Briefly, I'll give an example from an interview that Steve and Dennis did. So they interviewed Vietnam War POWs, Dennis Charney and Steve Southwick. And what they learned is, some of you might have heard some of these stories. So John McCain being an example, James Stockdale being another example. These were airmen in the Air Force. They were shot down over Vietnam. They were in isolation cells and tortured for years. They weren't in a room with other POWs. They were in their own concrete cells. And what they learned is that they needed social connection to survive, and they couldn't see or hear each other. So they developed essentially a Morse code. They were tapping on a bar or tapping on the cell so each other could hear, and they would have whole conversations. And they developed their own moral code and their own way of communicating and supporting each other through torture, through this tap code that they developed. And it really shows, A, the innovation of the human spirit, and the importance of social connection, even in the most extreme situations. And as I said, just like optimism, social support is, by and large, reliably associated with good coping after disasters, after traumas of any kind, before, during, and after. And what I really tell people is if they're going into a situation they know to be stressful, for example, medical training or graduate school, build your networks first and know who you can lean on first, because it's very hard in the thick of it to develop new connections. I certainly made friends in graduate school, but during finals week, I don't want to be going out and making new friends. I want to know who's on my phone that I can reach out to ask for help. And what we know is the converse of this, loneliness, is quite toxic to your physical well-being, to your psychological well-being. And there's a lot written lately about the loneliness epidemic, especially in older folks, but you could also see it in teenagers, for example, and we could talk about this for a long time. A lot of teenagers feel lonely, and they might have 1,000 or 10,000 or 100,000 Facebook friends or Instagram or TikTok, but those are not, generally speaking, pretty deep connections. They're superficial connections, and there's a lot of emotion attached to those connections, but those, generally speaking, are not thick and thin friends. They are sort of fair weather friends or temporary or not even real deep relationships. They're very superficial, and they don't really add up to much in the long run, although a lot of emotional weight is put into them. Just as an example, very crowded slide, but a win for psychology here. There are some researchers, I guess 2018, pre-pandemic, who are trying to develop a screening measure for risk of what's called post-ICU syndrome. So folks who have done work in an inpatient setting, when someone's been critically ill, post-ICU syndrome is there a kind of PTSD or depression that people can experience after discharge or develop after discharge from the hospital for severe illness. And turns out, when they looked at what predicted it best, it was this question in gray. Not how sick they were in the hospital, how long they were sick, the intensity of their medical treatment. It was, do you have someone who can help you when you go home? Do you have the social support in your life? Was the biggest predictor of whether somebody developed post-ICU syndrome, PTSD, depression, sort of a combination condition. Nothing medical, just this, a sort of social psychological factor. And the other scale, the survival curves on the left, this again is not my research, but done by others, shows that those adults who came out of the hospital after admission, after an illness, those who were more socially isolated died earlier. So there was a real relationship between loneliness and lack of social support and medical health as well. And we teach people to really take inventory and take stock of who's in their network, who can they turn to. And there might be somebody they can turn to for work stress, but it might not be their partner at home. It might be that they turn to their partner at home for something emotional, but maybe not their boss. So they kind of have to piece together different people for different things. It might be too much to expect one person to fill all of those roles. The other thing that I often say in teaching is that unplanned check-ins with people, it turns out, are really important. And by that I mean, research has shown that friend A randomly checking in by text or by phone with friend B is both good for the well-being of friend A and friend B. Not a planned phone call or planned hangout or some meetup at a bar, but a random message that says, hey, we haven't spoken in a while, how are things? That is both good for the receiver and the recipient, and I do that myself. I often go through my phone and text people that I haven't spoken to in a while and check in. It feels good for them. It's generally not weird, and it feels good for the person sending it to. And it doesn't take very long. And I'm just going to say a couple more things before I wrap up. The other, one important thing is that we teach self-care, but when we teach self-care, it's not unitary or monolithic. We don't say, for example, you should meditate. Yeah, people should meditate, but it's important to understand that they need different tools in their toolboxes for different levels of stress. And this is a framework that we use from the armed forces to begin to teach that to leaders in particular, but also to line staff. This is called the stress continuum model. You might be familiar with it. There's like 50 different pictures of this online. And the idea is that people develop a vocabulary for understanding when they and their teams are functioning at their best, having transient reactions, having hours to day long reactions, or having more sustained entrenched reactions that might even become psychiatric syndromes. And that you need different coping skills and different tools in your toolbox for these different levels of stress. You can't expect on your worst possible day to also get on the Peloton or eat right. You need different tools to respond to how your body is doing and what your body needs. And this is actually coming out of work of the Marine Corps. There's a great paper, about how this was developed for use to train leaders. Very briefly, we actually do a lot of training. Every new manager in the institution at Mount Sinai gets an hour training by our center on psychological safety and trauma-informed leadership. And the idea here is to teach people to foster a sense of psychological safety within their teams, understanding that this operates at sort of a macro systems level. And when they notice signs of stress within their employees, within their staff, to reflect that back and to connect them to the appropriate resources. We don't want people to be the therapist for their staff member, but we want to give people the vocabulary and flexibility and comfort in showing appropriate care and making those connections, and also weaving in an understanding of the wide range of stress that people experience in their personal lives, but also at work, into policy and procedure. To taking that idea that being a healthcare worker these days is pretty tough, and being a person in New York, especially in the United States, is pretty tough. And we want to take that understanding and awareness from a trauma-informed perspective and weave it into how we treat people at the institution. I'll give you one example. When we asked nurses a couple of years ago about verbal abuse at work by a patient or a visitor, 60% of nurses that we surveyed said at least once in the past year they'd been cursed at or insulted by a patient or a visitor. And 30% of nurses said they'd been physically assaulted at least once by a patient or a visitor. So pretty significant. It's come down some, but it's actually raised during the pandemic. There's a whole bunch written in the literature about increase in workplace violence in healthcare institutions after the pandemic or even during. And it might be related to just mistrust of healthcare workers. I mentioned this already, trauma-informed leadership. We teach about this, weaving this understanding into how they practice as leaders. And this does not come naturally. You don't just get a textbook on this when you become a leader. You have to be taught this. It's not typically part of what leaders learn when they take up managerial positions. I'm going to highlight right before I end the clinical services that we provide to our workforce. So I talked about education. I didn't really talk about digital health that much, but we have an application that we use to teach resilience. We do a lot of outreach and engagement. We talked about community work. And since October 2020, we got impaneled with all of the different insurances that our workforce has. And we've provided moderate term CBT and medication management to pretty much anyone who comes to us who works for Mount Sinai. So we've done 30,000 treatment visits in 5 years, largely in CBT, largely about 14 sessions, including med management. About 60% of those folks are just doing psychotherapy and not medication. And we found it to be really highly effective. It's confidential. It's in our medical record system, but behind some privacy protections. We bill out to insurance, so we can be fairly self-sustaining by that insurance revenue. And we've published on the outcomes. This is pretty good, almost clinical trial level outcome data on CBT. So we train our clinical social workers, a lot of our psychologists already have had training in CBT, and we see very dramatic reductions in rates of screening for depression and anxiety and suicidal ideation in the routine measures that we administer over the course of treatment. And this is comparing pre-treatment intake scores done even before they meet with a clinician the morning of their first visit, to scores obtained from their 14th visit. So these are, generally speaking, 1-hour CBT psychotherapy visits, generally over a video platform, over the course of about 3.5 months. So we're talking about 14 visits spread over 3 months, having a pretty significant impact on how these healthcare workers are doing. And we see a full range of folks in the workforce: physicians, nurses, admin staff, security officers, pretty much anybody who works at Mount Sinai is represented in our clinical sample. And right now we're taking care of about 400 folks, but we've historically taken care of several thousand. We've also, this is my second to last slide, we've also done a lot of work understanding barriers to care. There's a lot written about mental health stigma in healthcare workers, just like in law enforcement. We've done some of that too. And certainly for physicians, there's more stigma around help seeking, maybe psychologists too. In both of these papers that were published within a couple of weeks of each other recently, the biggest barrier that healthcare workers endorsed was not having the time to even try to find treatment, because they perceived it to be too burdensome to even try to figure out where to get help. Not stigma or what their colleagues think about them, but simply time. Time to engage and time to look. And that's something that we really try to approach and to address. But again, these are also open access. You can take a look at them as well. And I'm happy to share afterwards. I will just mention that we also do a lot of work measuring resilience. I mentioned this as we were joining at the beginning. A couple of years ago, we developed a scale called the Mount Sinai Resilience Scale, where we take these factors that we've studied and that we teach, and we put it together into a self-report measure of psychological resilience that understands resilience as a set of attributes that can be trained rather than a personality disposition. So arguably something like the CD risk, which is the Connor-Davidson scale, kind of sees resilience as a personality trait. This kind of sees it as something that psychologists or other folks can teach a population or a group of individuals. And so we put this out there into the field. It was published in Psychological Trauma, I think last year, and we have a couple more papers coming out soon. And this, I'm going to wrap up now. This is my dog, Membrew. This is the source of some of my resilience. He's 14 and the most adorable miniature schnauzer I've ever seen. We've had some funding support that I'll acknowledge here. I'll certainly acknowledge the rest of the support from my team at the center, lots of psychologists that we work with and social workers. I have a research assistant who's been really prolific in putting some of these papers out. And I'm certainly happy to share my email address too. You can email me offline afterwards and we can chat either about some of the work or other things. And I'll take questions with 6 minutes to spare. Talking very fast, but plenty of time for questions.
Thank you so much. That was wonderful. Lots of information. We're waiting for any question you may have.
Don, I'll just jump in and thank you for your talk. It was really, really interested, and I really enjoyed hearing more about your work. I think resilience is such an important topic, and we don't hear enough about it. We don't talk enough about it. So I just really appreciated your presentation.
And I'm also happy, I saw the comment, I'm happy to share my slides with the organizers. I'll just make sure there's nothing that's unpublished and then share it back.
Before something else comes up, what just came to mind, speaking about resilience, is for some reason, and maybe you can help me connect these ideas, are online communities who tend to promote the opposite of these effects.
Yeah.
Primarily like, around like disordered eating, for example, and like encouraging people to not, seek services or seek help in almost like, I don't know if it's, crabs in a bucket scenario or what, but have you had any sort of inkling of researching like the antithesis, like almost the opposite side of like people
Right.
encouraging not being resilient because
There's a Stoic philosophy quote, I think it's from Seneca, essentially something like you can something, let me see if I could figure it out what exactly something like you're only a victim if you choose to be a victim. That is to say that things happen to you in your life and they might be affecting you, might be victimized by them, but if you choose to be a victim, you assume that identity. That's something that you can have control over how it affects you and how you identify and move on afterwards. And it relates, I think, in part to your question, but I do am troubled by people who say, this is my identity, this is who I am, and the world has to deal with it, rather than I have some personal responsibility over my behavior and I maybe ought to do some accommodating to the world.
Thank you. Yeah.
There's maybe a philosophical thing in there about how we're
there's in a more layman's term way
our
of
sense
it.
of
I remember
responsibility.
a quote of saying like mental illness is not your fault, but it is also your responsibility in
Right.
managing that. And so I see somebody in the chat saying that, can you speak to the concept of compartmentalization as it relates to resilience?
Yeah, so I will say, well, let me Jen and I had this experience with first responders and police officers. There's a certain amount of compartmentalization that is required for certain jobs, being a cop, fireman, surgeon, physician working in healthcare. However, it is only useful for a specific time and place. It's not particularly helpful when you have to go home and talk to your partner or your children, and they perceive you to be cold or unaffected or distant. So I think it's about flexibility, using a particular skill in a context in a short period of time where it is necessary, and when it is not, adapting and changing to something else. So again, helpful for a particular moment if patient bleeding out in front of you, but not helpful when you have to, pick up your kids from a soccer game and they're trying to tell you about their day and you're not reacting. Tim, hand up.
Yes, hi. Fantastic presentation. I work a lot with teens and young males. What would be your thoughts or recommendations regarding how to address the black pill or the incel movement that's becoming, I don't know, gaining some traction among younger males?
Yeah, I mean, I think that's not a particularly helpful narrative to assume that the world is like plaguing you in some way and that everything is everyone else's fault and not your own. And that you have no sense of control and you're again a victim of a certain belief, like the rest of the world is victimizing you. Women are victimizing you by not dating you. Again, does not put the responsibility on you. You're sort of externalizing blame, and that's your belief system, and that can lead to violence for sure. It can lead to a sense of othering, a sense of furthering disconnection, and I think what I would say is that we need somewhat better role models. I was even having a conversation. I'm writing a chapter about moral compass, and I'm thinking, who am I going to interview who I think has a good moral compass and is a good role model for men and boys? And I will say out loud that I don't particularly like Jordan Peterson.
Thank you so much. I think we can move forward with the closing remarks. Thank you again. That was a wonderful presentation, something that we all need a lot. In the future, I will contact you in terms of possible trauma-informed teaching for professors and also trauma-informed supervision. Thank you.
Absolutely. And I'm happy to share the slides. I'll probably do it later today or tomorrow.
Thank you.
Take care.
All right. So before everybody goes, I just want to thank you for joining us this evening. And in regards to our next event, I'm excited to announce that we're going to have Dr. Melissa Burton. This is an event that's going to be in person and online on Zoom. It's going to be December 4th alongside Dignity Grows, which is going to co-host an event at the Jewish Community Center at Woodbridge. And I want to emphasize that together we are the facilitators of change and empowerment for individuals and our community. So regardless of the amount, your generous donation to the Social Justice Speaker Series helps ensure that education and awareness remain powerful tools for making a difference in our community. So with that said, the donation link and mailing address are going to be available in the chat if you'd like to support us. And remember, for those registering for continuing education, I invite you to complete that CE evaluation link to receive your certificate, which is also going to be added to the chat. And once again, thank you so much for joining us this evening.
Thanks again, everyone. Bye-bye. Bernadette, this is great seeing you. I cannot hear you, but this is great seeing you today. Thank you for participating. Have a good night.